I'm going to start off by introducing you to one of my heroes, who's Anders Heil, whom I met and spent a little bit of time with back in 2008 when the Worldwide Glaucoma Research meeting was in Queenstown, and I got to go to that, and turned out that Anders was a keen birder as well, so we had an hour with him in the Dart River trying to show him some of our local birds. Of course we found none in that hour that we walked up the river, but I gave him a book about bird watching in New Zealand, and he gave me a classic Viking novel to read because he comes from Sweden, and he is truly one of the heroes in glaucoma research, because he really is the main champion of the CETA algorithm for the Humphrey field, and we've had that for 20 years. 20 years ago really that he did that sort of first work with others, but particularly him on the CETA algorithm that we've known and loved for so long. And so I thought we would, if we can access a video.
There were a number of large randomized glaucoma trials that were completed between 2000 and 2005, and the results of those trials have changed the usage of perimetry, because the trials showed us that we had to measure rate of progression. Historically, perimetry was used for diagnosis and for determining whether an eye had gotten worse or not. But the trials taught us that the question of whether an eye has progressed or not is not the most important one. The important question is, what is the speed of worsening the rate of progression? And in order to measure rate of progression, we need more data points. So as a result of the results of the trials, new clinical recommendations came out, for instance, in the European Glaucoma Guidelines, recommending that we should obtain more visual fields, particularly the first few years after diagnosis. The European recommendation is 3 fields per year the first 2 years after diagnosis, which is much more than we used to do in the past, and therefore the need for faster tests increased. Large changes don't take place overnight, but my hope and our goal with creating CETA Faster is to increase the frequency of field testing so that clinical reality comes closer to the practice recommendations. And if that happens, I will be happy. Well, the differences between CETA Faster and CETA Fast are quite small. And I think the simplest way of describing it is that in CETA Faster, we have made a few corrections that we were not aware of 20 years ago when the initial CETA programs were released. So actually the error-related factor, the accuracy and the precision of CETA Faster should be the same as of CETA Fast. That is our goal, and we consider the data between CETA Fast and CETA Faster to be completely interchangeable. So this development of the CETA strategies was a very large step forward, involving a lot of work, but the extra work needed to develop CETA Faster was considerably smaller. It's all based on almost identical concepts. And I think that we can say that CETA Faster and CETA Fast will give identical results, or the difference between the CETA Fast test and the CETA Faster test will be the same as between 2 CETA Fast tests. Yes, I really see CETA Faster as becoming the new standard. When we developed the CETA programs more than 20 years ago, we designed CETA standard to be the golden standard for parametric follow-up, and CETA Fast as a similar but slightly less reproducible test. But clinical usage and research has shown that in clinical reality, the differences between CETA standard and CETA fast are very small, even if CETA standard theoretically has a slightly better reproducibility. And therefore, of course, many users of the CETA programs have converted to the CETA fast program instead of the CETA standard. And for instance, in Sweden, where I live, 30 out of 32 eye departments use CETA fast. So I think that this is the time we can reduce the test time by going from CETA standard to CETA faster by about 50%. And therefore, I think that now is the time to do the conversion. At least that is what we will do in our university department in southern Sweden. And by doing so, we will be able to do more tests. I think it's more important to do more tests than to do standard as compared to fast or faster. I think that most ophthalmologists and glaucoma specialists share my view that it is more important to take more fields, and therefore by shifting to CETA faster, we will be able to follow the recommendations more closely than what is done today. So I think that the acceptance of CETA faster will be quite quick, actually. We should have a loud mixture of CETA fast and CETA standard. In follow-up analysis, they are very similar, and it is much more important to have data points from all the tests than to have all the tests to be 100% identical. Well, we have tested CETA faster in its various development phases in Malmö since the beginning of 2013, and there has also been validation going on at the Humphrey Instruments in Dublin, California. Right now, we are conducting a 5-center study in 5 centers in Japan, in Hong Kong, here in Finland, in our place in Sweden, and in Berkeley in the United States. I feel confident that the results will show that we can make this shift.
Back to there, good. So that would just give you a little taste for Anders Heil, and so you could feel like you got the gist of his thinking behind CETA faster. A year ago, for those of you who are here, we talked about that paper that he probably referred to and that underpinned the efficacy of CETA faster versus CETA standard being a good way to go. And so I'm not going to talk about that particular part of it, but I'm just going to move us on a little bit from there. After that discussion a year ago, I didn't actually make the jump immediately to CETA faster. I thought about it a few times and didn't quite get there. As always, it just takes another little prod sometimes to change something in your practice. And the change really came when we had to upgrade our hardware and got a new machine, Humphrey Perimeter. And before I knew it, it was running in our office, and our usual field technician had taken instruction from the Humphrey salesman rep about what to use as default test, and I started getting tests coming back with 24-2C CETA faster, and that was algorithm I didn't quite recognise and wasn't so familiar with. So although I knew the faster was a good way to go, but I didn't know what 24-2C was about. And so it quickly had to find out and go and read the manual again. I hadn't done that for 20 years really for the Humphrey, and just find out what the algorithms were and what the test pattern meant. And then decide for me, and really for our whole practice at Southern Eye, perhaps potentially as well, whether that was going to be our default testing algorithm or not, as the Humphrey reps recommended. So that's really where this talk comes from. I'm just going to take you through our first really 3 months, or my first 3 months experience of that new algorithm. And it was particularly poignant, I suppose, because immediately we started using that, I saw 1 or 2 tests coming back that didn't quite marry up with the ones I'd seen before in terms of series. And I thought, this is a wee bit different. I wonder what that means. And particularly 1 or 2 that seemed to be missing early glaucoma defects with the new machine, new testing algorithm compared to the previous one. And so I collected all those up for the 3 months until lockdown, first New Year really until lockdown. And I'm going to take you through those and just show you my experience, and we can discuss them as we go. Getting back to the birding theme though, just like birding, glaucoma really depends on looking in the right place for something and knowing what you're looking at. This is a group of birders who are usually completely oblivious to anything else going on around them apart from the birds out in front of them. As you can see, one of our party is standing in a puddle. We're actually looking for a rather obscure tawny owl in a tree out to the right, but not far away, further down the road from that point, and that was up in the high Andes, the cloud forest on the eastern slopes of the Andes in Ecuador last year. So not far down the road on that little expedition was this beautiful bird, a quetzal. Getting back to the perimeter, that's just the paper we talked about a year ago for those of you here, just comparing the efficacy of CETA faster with the previous CETA standard algorithm. I'm not going to go through that again. We've sort of taken that as read, that it's useful and acceptable and good step up in terms of efficiency and also good enough accuracy-wise. So if you go back to the Humphrey manual and we see what all these algorithms are and what they mean, just to put them into perspective, we started off, of course, with full threshold back in the late 90s, 2000s, until CETA standard came along. So this is the one that Anders Heil and others worked on 20 years ago or more, and that we've really depended on for a long time. And then, of course, we had CETA fast, which was a little bit quicker, and more recently CETA faster that we've talked about. And this is where they all fit in terms of testing time, because that's the title of the talk, is, how fast can we go, and is there a limit to how fast we can go without cutting too many corners and missing information that we want to collect for our patients. So this is testing time for patients, and it's quite a significant time frame for patients because, as we all know, patients hate this Humphrey field testing machine because it's all about fine subjective discrimination around the threshold, and that's always tiring and hard work. So the old CETA standard took on average 6 or 7 minutes, CETA faster a bit better, and CETA faster 24-2 that we talked about a year ago was the shortest and would typically take about 3 minutes, about half the time of the previous testing strategy, which is quite significant. But what was CETA faster 24-2C? Fits in the middle there a little bit. Well, it turns out that Humphrey had produced another testing pattern for us, and the C means central. So they've assumed that some clinicians might perhaps do both the 24-2 old algorithm, which is this one here, where you just test it out to 24 degrees, except for 30 degrees out to nasal periphery to pick up the more glaucoma information. And they might also marry that up with a second test, looking at the central 10 degrees in a bit more detail. I've never done that, and I don't know if anybody else in this room would have used both of those together. But they decided to combine both of these and add a number of points from the central 10-degree pattern into this combined one, and it's the 24-2C test. And these are the extra points that are tested in the new algorithm. And that's why it is just not quite as fast as the 24-2. It's a little bit longer just because of those extra points. So this is the testing pattern and the testing algorithm, CETA faster, that the reps were recommending we use on our machine, and my technician started using right away without sort of even thinking about it, which is fair enough. And so what do we think about that? Just before I go on, I'm going to show you all the examples of the fields I collected, and we can just discuss them and perhaps interact on them a little bit. A recent paper in June issue of Ophthalmology was relevant and quite interesting. Maybe more on this subject later, but this is a artificial intelligence technique for evaluating visual fields and trying to learn from, or deep learning really, simply observing a huge database. This was 13,000 eyes and tests just run through this AI deep learning methodology, and really just they were asking this machine, black box if you like, to record all the patterns of defect found in the central visual field and to classify them. And this is what they came up with. They classified 17% of superior loss, 12% inferior loss, rather diffuse loss, 20%, and a few other odds and bods down here, resolved the sort of typical pattern they saw in this huge data set into various patterns, and then could, for an individual case like this one here, resolve out the patterns that might make up that sort of more individual test result. So for instance, in this one here, the AI machine decided that this was 58% of that pattern, 35% of this pattern, and 6% of this pattern, to give you what we ended up with in this particular patient example. So you could argue, and they were arguing, that there might be some sort of pathological correlation between the visual field patterns we see and what is actually going on in the nerve fibre layer, retinotopic organisation, in a way that would let you first of all measure, but also maybe understand what's going on clinically. So here's the first of about 9 or 10 examples I'm just going to work through, so you can share my experience of this algorithm and help me interpret it if you want to. And maybe along the way we can talk about some of the visual field patterns we see. They're all quite similar, I think. But these are all the ones that came across my desk that didn't look quite the same as the previous test. So, and as you'll tell you at the end, this was out of about 100 cases all up over that 3-month period. So these are all the ones that I flagged as not being quite equivalent. So the vast majority of them were actually pretty good and pretty similar, but these are the ones that weren't. First of all, this one, so here's a 24-2 threshold test, and this one's done a year ago, and here's a left eye, reliably done, except it says low test reliability there for some reason, but the other stats are quite reliable. And here's a year ago, March 2019, June 2019. So there's certainly something going on, superior arcuate really, and it looks reasonably bona fide superior arcuate. And here's the 24-2C test that doesn't seem to pick it up. So that's and it's a pretty good test. That's possibly a little bit alarming in the sense that there's nothing much showing up here, whereas previous tests were showing something. So that did raise a red flag or two for me that, maybe we're making this very short test, 2 minutes 40 compared to 5 or 6, 5.5 minutes, half the time. That might be good, more reliable perhaps, but are we missing something important? So that was a question I was asking in all of these, and you can see for yourself what you think the answer might be, or help me interpret it. Here's another example. Again, I've got 2 previous tests here. 24-2, done in December 2013 for the right eye, and here's one on the same patient, same eye, done in 2018. And again, I think you'd agree that's a reasonably bona fide superior defect. You'd pass that for a glaucoma defect maybe. Any dissent on that or any discussion on those fields? And here's the 24-2C test that seems to be not nearly quite so dramatic and dense. Similar extent, but not so dense. Very reliable in terms of fixation losses, false positives, false negatives, and a 2 3/4 minute testing time compared to 5. So there's half the time tested. Reliable test, but maybe missing a little bit. And then all the rest, all the next 9 or 11, I think, are just same test, different test algorithm done on the same day. So this one here was the one done on that day that I looked at compared to my previous test and said, oh, that's a wee bit different. So I sent the patient back to the technician to do the older, my familiar algorithm test same day, after this one, admittedly. And so these are all the comparisons on that same day test between the 24-2 standard one I'm comfortable with on the left and the new testing algorithm on the right. So maybe somebody wants to comment on that for me and tell me what you think of that comparison. Yeah, these are the same day. So all these, the first 2 examples I gave you were a series of a couple of tests going back 2 or 3 years, and the one on the right was the recent one. But these are all ones that I have done on the same day. So this is same day, so you can see this is 6, hold on. Oh no, that one's not, sorry. Must be one more of a, older example. That was done in 18, take that back. This is just a little bit less dense and a little bit less picked up on the recent test than the previous one. Must be the next ones that are all same day. Yeah, sorry, that was one more of the older series. But from now on, they're all same day, same, different test, same day. So here's one, 28th of January. And this one, first one done at 2:12 p.m. This one done half an hour later when I picked this up and said, oh, I'm not sure that's quite as good as the older one I'm familiar with. And go back and do the older one again. And this is what we found. So here's the test that came to me first. And it looks pretty good. There's not really much you'd pick up there as glaucomatous. But here's the one that I had been watching in the past, the field that I'd seen before, maybe a series of them, or at least this one here. On the older machine, that alerted me to the fact that I wanted to do this again on the longer test, and this looks to me like a reasonably significant inferior nasal step. Do you agree? So that one's a little bit of a worry that we might be missing something on this machine, that this test that we
were picking up previously. And again, you see the difference in testing time to just over 2 minutes versus 4 minutes. So roughly half testing time we're doing in all of these tests, which patients love. I mean, it's great for patients and great for office efficiency and great for everything, so long as we can be confident in these tests. Okay, another example. So you get the idea now. You can tell me about that one. These are on same day, February 13, February 13. On the left is the comfortable, familiar algorithm, 24-2, CETA standard, one we know and have loved for 20 years. Took 4.5 minutes in this particular patient, compared to 2.25 minutes with the new test. Both nice, reliable fields. And here's a early superior nasal step in the old test, and seems to be missing on the new one. Someone tell me about that one. Now you've got the hang of it. Same or different? Yeah. So again, you worry about whether or not we're missing a little bit of real pathology with the new test that we picked up with the old one. This one's flagged as low test reliability. Not quite sure, unless it's just the fixation losses, but sometimes it flags that up without really quite having evidence to back it up. Whereas this one is, look at that, no fixation losses, no false positives, 5% false negatives. So they're often nice, reliable tests, these ones, being shorter and patients not fatiguing, particularly when we come to the second eye, maybe. But there's the difference we're looking at. Is that acceptable? Look at the grayscale, all that stuff there. I mean, you might not necessarily place too much weight on just superior peripheral loss alone, and you could argue that's a little bit in that category rather than right down here on the nasal step zone, but still looks a wee bit worrying to me. Here's another one. Different test, same day, 5 minutes just over and 2 minutes 20. Quite a few fixation losses. All this stuff down here, not that specific, but noisy, but nasal, inferior loss, and not much of it showing up here. Another one, January 30th, 24-2 CETA standard on the left and the new one on the right. 6 minutes it took to do this one on the old test and 2.5 minutes on the new. So that's a bonus. So you see what I mean about all these extra tests in the middle. So there's all the, and it's a little bit higgledy-piggledy. They don't seem to have much logic to them, but they have been chosen as best representative of those that might pick up central field loss and glaucoma. So they've been put in there for a reason from that 10 degree additional field grid. And so you see the extras there. And so you do sometimes see more spots, more defects showing up in that central area just because we're looking in more places. But in general, there seems to be a bit more density and a bit more specific localized loss showing up superior nasally in this eye compared to there, which is a bit more diffuse. Here's another one, 66-year-old, 5 minutes 14 on the old test and 3 minutes on the new. And any comments on that field? What about this field here? What do you think of that? Is that typical glaucoma or not quite typical? Something else? What do you think of this one first? How many think it's typical glaucoma? How many don't? Not sure. Well, yeah. Most things can be caused by glaucoma. You can get all sorts of varieties. You saw in that previous AI plot of all the different parameters you might get, all different kinds of field loss you might get in the central 10 degrees. And this is no exception. I mean, you certainly do quite often see a defect just like that. And you often see this almost square box right there simply because we're testing one point there, I think, and you just get a square box and it looks rather odd. It doesn't really mean a great deal, just lack of testing spots really. But that's fairly typical of a superior nasal step and a little bit of breakthrough scotoma paracentrally in the superior arcuate radiation. So yeah, it's typical glaucoma. We just don't see it quite the same in this new test. But if we look at the pattern standard deviation, which is where the money really is, and we should be looking at that first off, not necessarily so much the grayscale, we see just a somewhat different pattern, but it's still picking up quite a lot of loss supero-nasally, just maybe a little bit different. But when you first look at those two grayscales, you think, oh, there's a whole lot in here that we're missing on this one. But look at it more carefully, and it's just a wee bit different, but not so alarming maybe. Here's another one, 64-year-old, 6 minutes on the older test and 3 minutes. You see they're all about half time testing time, which is nice for patients. Here's the original low test reliability, maybe 14% false negatives and quite a few fixation losses, so not such a good test this in terms of reliability, whereas the new test is certainly more reliable, no fixation losses, and not so many false negatives at least. And not a lot between those two. A little bit different though. Maybe that's the point I kept that one out for. It's just a wee bit different, not quite so consistent. Getting to the end of our series, there's not too many more, I don't think. Here's one 81-year-old who took 6 minutes 40 in the old test and 3.5 minutes in the new. And that looks a bit different, do you think? So this one maybe is picking up something that wasn't there so much in the older test. So this is maybe one of the few that's actually picking up something that maybe is there and wasn't picked up by the other one. So that might be a positive result and a better pickup, depending on which one you believe. Here's another one, 62-year-old with nearly 5 minutes on the old test and 3.5 in the new. Here is a pretty good test and probably a fairly bona fide typical superior arcuate scotoma. Looks a little bit different than the ones we had before because there's a few more points put in there. Those 10 extra points just make the pattern sometimes a little bit different because it's picking up more of it and displaying more of it compared to what's displayed here. But that might be a more accurate depiction of what's actually going on than the older one. Not sure how many, in fact that's the last one. So the last, I think I had them summarised in this last slide actually. So counted up the number of tests I'd done in that 3-month period and it turned out to be 109, so which is quite convenient because we can almost say this is 100% really. If we take off a few that exclude 9 of those, we have 100 and we have 100%, close enough to it. And you could say that 11 of these, or maybe 10% of these seemed to be missing something that I thought was there on other algorithms. And 3 of them picked up something that was maybe not shown up with the older test and maybe is real and maybe was there. So, but remember that most of these tests were similar to previous ones and what I expected to see, and were probably quite accurate, reliable. So that's what I found with that audit, and I just wanted to share it with you in terms of letting you know what you might be in for if you want to use that new test. And I think we should have a bit of question and answer and discussion about that, and you tell me, as much as I tell you, whether or not you think that new testing algorithm is good enough to use.
Do you now feel you've got to do both?
Do I?
Really what's going on? Do you now feel you've got to do both?
No, I don't think so. I'm not doing them now. I stopped doing both. I did that up until lockdown, and then decided I've done enough now.
So which one are you favouring now?
I am still using the 24-2C, and that's probably what I'm going to recommend doing, but it's a little bit of a trade-off. As you can see, it's not cut and dried and absolutely definite, but I guess that's based on experience. I think it's good to know that there are some things you might miss and it might be a wee bit different. It's having been through that double up and duplicate, and was very useful to, first of all, give me confidence that most times it was pretty good, but secondly to show up the few times when it wasn't quite so accurate. But you're never quite going to know which of those two tests are giving you what's really happening. We're just trying to estimate what's really going on and looking for those birds in the bush in the right place and hoping we're picking up the right one and seeing what we know is possibly there, and look in the right place for it. And the other big advantage with the new test is that patients love it, but not only that, you tend to get a lot more reliable tests and much fewer fatigues and low reliability flags and so on. So that's got to be good, because it means you're getting more what you're looking for, you're getting it more accurately and more reliably. So I think that possibly makes up for some of the misses you might have because you're taking a few shortcuts and measuring things a little bit quicker than perhaps you are. You're not doing quite so many retest pickups.
That progression was the thing you're looking out for now these days, so you're doing those tests 3 times a year for these people.
Well, that's what Anders Heil says, and that when I was in Oxford in 1989, and I first sort of came across the idea of computerized perimetry. We were doing it with old full threshold algorithms. It took 12 minutes or something horrendous on those first machines. And I remember a couple of sort of scientific officers that were in the eye department at the Oxford University clinic that I was working in for a year, scoffing at the idea of doing perimetry, computerized perimetry, and saying that, this is all statistical, all the stuff we're collecting now and all the interpretation we make of those tests is statistical, and all of that means you need to have many tests to make those statistics valid, because just one test on a one particular day in itself is not valid. You can't sort of say this has got a 95% probability of being outside normal range unless you've got a whole lot of tests really to validate it. And so they were saying, maybe you could use that if you do lots of tests every 3 months or 6 months or whatever. So that was the first thing that's always been in the back of my mind. And then I think more recently I'm always quite surprised when I read the European glaucoma guidelines and so on, which Anders I think was referring to there, about how often you should be doing visual field testing, which is quite a lot more than I would do and maybe we would do here. Like what he said, every 3 months or 6 months, particularly in that first couple of years. And I guess we've backed off doing that because A, it's quite time consuming and patients don't like it, and we try and minimise the number of times we A, bring patients back, and B, put them through that nasty field test. But I think the other benefit that this gives, and Anders was telling us about, was that maybe we should just be doing tests more frequently, doing that shorter one, and just doing more frequent tests. So I think it's probably the way to go. So that's what I would probably do. But what do you think? You think it's a valid approach?
See something done where you did get a bunch of patients in the first 2 years after diagnosis and did film tests every 3-4 months with both tests, the faster and the original, and watch the progression and see if the progression is
Yep.
communicated with both tests to the same amount.
Yep.
Doesn't really matter so much where the defect is and how
No.
Andy just would have done that, wouldn't he?
Yeah. Well, he's talking about they're doing that now. I mean, this new test hasn't been around very long with the C addition to it, but so it is coming out. Yeah, I don't know it's quite out there in the literature yet, but it's probably coming. But yes, absolutely.
You know, the photodramatic fixation losses with the new test, is that just purely time, or do they test it a different way? It just seemed like vast on all of those 11 examples.
Yeah, they did, didn't they?
Is that just
I think it's a combination. The problem is we don't really know what's in that black box. And Anders hinted at, in that initial video that they've done a few extra corrections to how they test that and pick it up. And if you go back and think about how that CETA black box worked, which I haven't looked at for a long time, but knew it well sort of 20 years ago, it does a whole lot of things like fuzzy logic, pre and post test computation, goes back and retests things computationally that it sort of had in its data bank that meant it could get a more accurate threshold by redefining the number at the end of the test rather than what it had at the beginning. All sorts of quite clever tricks that the computer could do to fine-tune the quality of the data, and using a very clever Bayesian probability plot that means you can minimise the number of times you go across threshold and still get a very accurate assessment of where that threshold is. So all of those things that cut down the time from the threshold to the CETA test are still there, but I suspect they've made 1 or 2 further changes to that as well. So maybe that accounts for the fixation losses. I'm sure it's a bit of that and a bit of the shorter time as well.
Because the fixation loss seems to say like 0 out of 0. Whereas you get 3 out of 14 or whatever.
Yeah.
If it's 0, it's like are they doing it a different way?
Yeah.
Not doing it the normal, way that you do it on standard.
Yeah, no, they certainly do take a few shortcuts with fixation loss and assume that and measure it from other things, do it indirectly rather than directly.
Did you get that system where the shorter test was done first and then the long test after, or the other way around?
Other way around. No, these were all. Technician has the instruction to do the new test first because that's the one we're going to use. We're working on that provisional plan that what the rep came in and told us to do, we're going to do. Until I picked it up on that sort of first week and said, oh, do we really want to do this? And I said, oh, okay, yes, well, let's do it, but I'm going to keep a copy, a duplicate of all these cases and just look at them again. But they were all done that way around. So they were doing the standard first, and only when I saw that new test come back and looked at it compared to previous tests and thought, I think I might be missing something here, I sent them back for the second one.
The standard first, the long first, the shorter one.
The shorter one first, yeah. Then went back into the standard.
Any of those tests on someone with quite severe glaucoma? Does it look different from the original test and then the one?
These were all my patients for the 3 months. So, and there were some quite more extensive visual field losses in that 100. These are just all the ones that I picked that were different. And so they all, and looking back at them, I didn't realise at the time that they were all quite similar, quite early defects. They're just the way they turned out, those 11.
Would it be at some point the two visual fields ever end up looking similar to each other when it gets to a certain
Oh, maybe.
amount of glaucoma? Is it just the beginning of glaucoma that it's not picking it up, and then once it reaches a threshold, does it start looking
Maybe,
the same?
yeah, maybe. I mean, then we had a, well, as you know, 4 or 6 week break with lockdown, and we've come back now to busy again, and I'm just doing this new test as a routine now, and I haven't picked up too many issues with it, but and it might just be beginner's bad luck that we got all those at the beginning, I don't know. Or it may be that I saw them then and I'm just given up looking for them now and I think, I'll accept this and this is the new reality. And to some extent, you can never get everything absolutely 100% accurate with subjective tests, and you've got to, one point or another, say, well, this is what we're going to take as our standard, and if it's not picking it up here, and there is a small defect, well, we'll still see it soon enough anyway. And so, you've got to be practical about these things as well, and make compromises, and say, well, this is what we're going to do now. But I think I will still run with that now as our default test, but maybe do more tests on patients rather than being a bit more reluctant to them and putting them off for a year or 18 months. I might do more and get a bit more information, that way, rather than more information at the time the patient's here in terms of testing time. Yeah, no, unfortunately it doesn't work like that. I don't know why it doesn't work that way. I'm not even sure. Yeah, well, because we normally allow half an hour for a technician and patient to get the field test done. I don't know if we've quite got to the stage of saying, actually, we don't need to allow that time for the field test because it shouldn't take that long. It should be half an hour. It should be quarter of an hour we allow for each patient. So I haven't got to that step yet. But it's interesting looking back on how things happen, though, because I remember sitting here a year ago when I saw CETA faster, and that paper did suggest it was a good way to go and it was an acceptable way to go. I still didn't make that change clinically because I'm a slow changer maybe. Still didn't make that change right there and then, although it was in my back of mind that maybe I would think about it sometime. But it took something else to come along. We changed our machine, and before I knew it, we were doing this new test, and I thought, oh, okay, is that the right thing to do?
This is a bit of a tangential question, but you get referrals and optometrists who are using other visual field machines, so things like Medlons and things like that. Do you tend to find that the visual field results you find from the Humphreys are comparable usually to other visual field machines, or do you find tend to be worse on the Humphreys?
No, they're comparable, pretty much. It's just that I'm so much more familiar and comfortable looking at these, and I know what it means exactly, whereas I have to double think all the other modalities. I'm sure they're telling the same thing. And, in terms of series, they'll pick up the same things quite well too. It's just that around the world, in any research paper you pick up, it's going to be this Humphrey field machine, and that CETA algorithm is a very good one, and it just works really well. And it's just the one I'm familiar with most, but others are fine and work well, I'm sure.
You saw a really obvious OCT nerve fibre lab defect, and then you did the CETA faster visual field defect, and you didn't find a defect. Would you be? Do you want to go back and do the other one?
Yeah, I might sometimes. Yeah, I think you've got to always think about what you're doing and not just do things blindly. So although I might and you might have a default test that you do routinely most of the times, sometimes you want to think, is this the right test? And when you look at what's available in the machine, and there are obviously, you can go back and do the out to 60 degrees if you want to, or you can go back and do the central 10 degrees and fill in, what you might be missing on the 24, as some people apparently do. Yeah, so you could do that. But it's also not uncommon to get a significant OCT loss that doesn't show up in a visual field, just because there's so much change happens structurally before it starts to show up on the field. But yeah, it certainly was a little bit worrying when I first saw those, thinking that maybe we're missing those earliest changes in the field test, and maybe this is a little bit further down the track that you're picking up that first field loss by this new test. So yeah, that's something to keep in mind.
Thinking of equipment changes, have you come across anyone using these virtual reality goggles to do visual field testing?
No. No.
Just hearing things and so on. Just wondering where that's going.
Are these self-help for patients, you mean?
No,
This is in clinics?
according to a colleague.
Okay. Right, right.
Well, this could be a way forward.
Oh, well, it's amazing what technology is throwing at us, isn't it? I'm just watching with interest, and there's a few more things coming out. I mentioned that one paper, but there's a few interesting papers coming out now that I might put together and a talk sometime about the new learnings about glaucoma from AI. And just when you have these huge big data sets, and it's both structurally on OCT findings and visual fields, like this paper I showed you, when you throw some sort of deep learning AI at huge big data sets, they can see things that we can't see on an individual basis, and they can pick up patterns and trends and analyze and resolve things into useful patterns that you can actually maybe imagine might marry up better with the pathophysiology that we sort of think is happening in glaucoma, or maybe teach us new things about the pathophysiology that we didn't actually quite see before. So that's an intriguing new line of research I'm sure we're going to see a lot of in the next 5 years. We'll wrap up in a couple of minutes, but unless there's any other last question or two, we can stay for more food and drinks.
This is unrelated, but is SLT work better, worse, or just the same on somebody with bigger dispersions?
See it so infrequently that I couldn't give a gut feel for it. It probably works a little bit better, just as in the same way that it works better in pseudoexfoliative glaucoma with that pigmented trabecular meshwork to take up the laser. But I don't think it's quite such a marked effect as we saw with the ALT in the past. The SLT doesn't necessarily need all that pigmentation to work, and it does work surprisingly often. Although I still tell patients there's about a 50% chance it will work well, but it's probably about a 70% chance it'll be working at 9 months, and a 40% chance it'll still be working at 18 months, and down to a bit lower at 2 years. So
Would you still start treatment purely based on visual field demonstration of progression, or just based it more on IP, or
depends. I would treat a number of patients that have quite significant structural loss with no visual field prophylactically. I wouldn't treat many patients with ocular hypertension unless they had very high pressures if they've got normal OCTs.
and what's very high pressure for you in terms of ocular hypertension?
Probably 30 is about the cutoff. Anything between 20 and 30 is fine not to treat, assuming everything else is there's not too many other major risk factors, and you've got a normal OCT.
Patient I think is 39, pressure's about 25, visual field's perfectly clear, and it looks great in the back of the eye.
Yeah, I'd probably still want to know what the OCT scan showed, but you say the discs are perfectly healthy. But if the discs are perfectly healthy and not at risk and small cups and confirmed by OCT scan, then yeah, you'd be happy to leave that. Sure. Any other clinical questions or other than fields if you want? No? Okay. Oh, well, thanks for coming, and thanks for helping me interpret those fields, because it's good to have your opinions about what to make of that data. But yeah, I think we'll just go with the new regime and see how that works in the longer term, but keeping in mind that occasionally might be missing something.